Good evening for those of you that have joined. Thank you for joining us. I think we'll give it one more minute for a few others to pop in. Okay, we'll get started. Once again, good evening, and thank you all for joining us this evening as we celebrate Lung Cancer Awareness Month and share advances in lung cancer screening, small cell screening, diagnosis, and treatment. This evening's presentation is supported by U Chicago Medicine and our presenters, Dr. Paderi with Rush Anderson Cancer Center and Dr. Desai with Endeavor Health. You will also be hearing from our Director of Advocacy in Illinois and Iowa, Christina Hamilton, who will be sharing an update on the State of Lung Cancer report as well as lung cancer screening initiatives. The American Lung Association's mission is to save lives by improving lung health and preventing lung disease. We are able to move our vision forward through our strategic imperatives, defeating lung cancer, championing clean air for all, improving the quality of life for those with lung disease and their families, and creating a tobacco-free future. Once again, we appreciate you taking the time to tune in this evening for education on lung screening. I would like to pass it off to Dr. Paderi and introduce him as he will lead us in recent advances in the management of non-small cell lung cancer. Thank you.
Thank you so much, Danielle. It is my pleasure to present to you some of the most recent advances that we've had in the field of management of non-small cell lung cancer in the past year. I have some exciting updates for you. I'm Kusha Paideri. I'm a medical oncologist at Rush MD Anderson Cancer Center, specializing in treatment of head and neck cancers and lung cancer. Next slide, please. All right, these are my disclosures. Next slide. All right, so this is the outline of the talk today. At first, I'm going to touch on some of the important definitions and some of the background that we have, the different treatment modalities that we use, the biomarkers and the definition of a biomarker, as well as the spectrum of the management of non-small cell lung cancer. Majority of the talk will be focused on precision medicine and targeted therapies in this space, and how genomic biomarker testing and targeted therapies have revolutionized the management of non-small cell lung cancer. Then I will switch gears a little bit and talk about immunotherapy. And in the immunotherapy space, I will also talk about how now we are doing more incorporation of immunotherapy in the management of earliest stage or resectable non-small cell lung cancer. And lastly, I will talk a little bit about approaches and strategies that we can put into place to mitigate drug toxicity. Next slide. All right, next slide. So as far as the tools for management of non-small cell lung cancer, to basically provide some context and to define terminology, in general, we use two large umbrellas or categories of treatment modalities. One umbrella is known as local modalities or local treatments, such as radiation and surgery. And another category, another bucket here is the systemic treatments that we use. And these are the treatments that essentially enter the circulation and they work on cancer cells wherever they are. And they include IV medications, oral or under the skin medications. And as you can see here, there are three large categories of medications, including chemotherapy, immunotherapy, and targeted therapies. Chemotherapies have been around for decades. We use them for many different types of cancers, such as platinum doublet chemotherapies. Immunotherapies are a newer invention that were developed in 2000s, and basically they entered the lung space as well. The larger group of immunotherapy drugs that we use are the immune checkpoint inhibitors that include PD-1, PD-L1 inhibitors, and other categories. Then we have biospecific antibodies that can bind to different types of antigens on the cancer cells, as well as some other newer drugs, such as bispecific T-cell engagers. And the realm of targeted therapies, as the name implies, there are medications that target a specific biomarker, including a cell surface protein or a genomic change, or essentially an actionable genetic alteration in the cancer cells. The larger category of targeted therapies include tyrosine kinase inhibitors, or TKIs, and we also have some other medications in this category, such as anti-angiogenics, and some also debate that maybe antibody-drug conjugates also are included in this part. Next slide, please. As far as the spectrum of the management of non-small cell lung cancer, stage 1 and 2, which is considered earliest stage in general, is treated with local modalities, including radiation and surgery. And stage 4, which is metastatic disease, the first branch point is to perform biomarker testing. And biomarker testing includes immune marker assessment, or PD-L1, as well as next generation sequencing. That's what the NGS stands for. And the next generation sequencing will tell us if there are any actionable genomic alterations, meaning changes in the DNA of the cancer cells that we have targeted therapies for. If the NGS is positive for any of those changes, then we're dealing with an oncogene-driven cancer, and the treatment will include targeted therapy, and otherwise it will be a combination of chemoimmunotherapy. The management of stage 3 is more complex. Stage 3B and 3C includes multi-level lymph node involvement, and in those situations, the cancer is considered to be unresectable, and the management includes a combination of chemotherapy and radiation. And stage 3A is a space here that is rapidly evolving. That's why I've actually written it in red. The first question to consider is whether the cancer is resectable or not, meaning that it can be removed by surgery, and then the next steps will follow. Next slide, please. So what is a genomic biomarker? A genomic biomarker is a genetic alteration or change in the DNA that can inform on a tumor's response to a specific treatment. And to put things into context for you, in the pie chart on the left, you can see some of the mutations that we knew back in 2012, including the EGFR and KRAS mutation. Fast forward 12 years later in 2024, we know much more about that now. It's a molecular superhighway, for lack of a better word. Even for a mutation like the EGFR, there are many different types of mutations that are described, such as typical and atypical mutations. Next slide, please. And this is a high-yield slide. So in this slide, you can see the summary of the different treatments that we have for oncogene-driven non-small cell lung cancer, meaning if the NGS is positive for one of those actionable alterations that I mentioned, then what are the treatment options that we have? You can see that for first-line treatment, there are multiple mutations named here: EGFR, ALK, ROS1, BRAF, NTRK, RET, MET, KRAS G12C, and HER2 are the ones that we have FDA-approved drugs for as of now. And the ones that I mentioned in red are actually the new developments since 2022. So they're actually new FDA approvals. Next slide, please. Biomarker testing, I think you can agree with me right now at this moment that thoracic oncology is precision medicine at its finest. And NGS and comprehensive biomarker testing is crucial in offering the right treatment to every patient at the right time. And it's recommended as of now for all patients with advanced or metastatic non-squamous, non-small cell lung cancer. And as of now, lots of research is coming out that's showing its role in patients with earlier stage disease, for management of patients with earlier stage disease. And it should also be considered for patients with advanced metastatic squamous histology as well. Next slide, please. All right, so now I'm gonna get to the updates. Next slide. Next slide, please. I don't know if it's moving. All right. Yeah, I think a few slides back, I guess it moved quickly. All right, very good. I think that should be the one. Perfect. So first off, I wanna talk a little bit about the EGFR mutation, and the EGFR mutation is the most common actionable genomic alteration that we are seeing, roughly in about 20 to 25% of non-small cell lung cancer. And on the graph on the left, you can see that EGFR stands for epidermal growth factor receptor. It's a cell surface protein that is expressed on the surface of the cells. And certain changes in the DNA of this specific, certain changes in the specific gene of the EGFR can result in constitutive activation of this protein. And when that happens, it results in pathway activation that will eventually result in cellular proliferation and carcinogenesis, meaning the development of the cancer. So the first drugs that were developed in this space, it goes back to 2009, 2010, when we have the drug gefitinib developed, and it received its European approval. And then fast forward to 2018, that was when you see this drug that is marked with in a red circle called osimertinib, approved for first-line use in patients who have metastatic or stage 4 EGFR mutated non-small cell lung cancer. And this was based on the phase 3 FLORA study, which I'm going to talk about a little bit back then. But since then, in the past 5 or 6 years, there have been many attempts to see how we can improve the outcomes for EGFR mutated non-small cell lung cancer. Next slide, please. All right, so the first study that I'm going to talk about, and I apologize that the slide seems like it's been moved a little bit, the font there, but the first trial is the LAURA trial that made it to the news. And the LAURA trial is a study that looked at the efficacy and safety of osimertinib, the same drug, for patients with EGFR mutated non-small cell lung cancer who had stage 3 unresectable cancer after chemoradiation. So to put things into context, historically, when patients have unresectable stage 3 cancer, the treatment paradigm includes a combination of chemotherapy and radiation, and we used to follow that with immunotherapy, with immune checkpoint inhibition. This trial attempted to see if instead of immunotherapy or placebo, we give osimertinib, does that result in improved safety or efficacy? And it turns out that it does. Next slide, please. So as you can see, and to describe to you what we are seeing in this graph, this is a survival curve or a Kaplan-Meier curve in statistical terms. And it shows the number of patients that are progression-free, meaning that their cancer is controlled over time. As you can see in the upper graph, in the osimertinib group, you can see that there is a lower pace of decline in the number of patients that are progression-free. In fact, at 24-month or 2 years mark, about 65% of the patients were progression-free, whereas in the placebo group, it was only 13%. So osimertinib received its FDA approval for use for EGFR mutated non-small cell lung cancer after concurrent chemo-RT about 2 months ago. Next slide, please. This is the FLORA trial that I talked to you a little bit about, so that I mentioned before. So this is a study that looked at osimertinib for treatment of stage 4 metastatic EGFR mutated non-small cell lung cancer. And these patients with this disease were randomized to receive osimertinib, which is one of the newer generation tyrosine kinase inhibitors, versus an older generation pill such as erlotinib or gefitinib. And the patients were evaluated for their progression-free survival and overall survival. Again, as you can see in these curves, the PFS and overall survival is longer, significantly longer in osimertinib arm, which resulted in the FDA approval of this drug a number of years ago. Next slide, please. And I mentioned that to now segue to this slide, which is the FLORA-2 study. So as I alluded to, after the approval of osimertinib, there have been attempts made to see what other strategies can be put into place to improve outcomes in this space. And the FLORA-2 looked into treatment intensification, meaning can we give chemotherapy in addition to the osimertinib to see if that can improve outcomes? So the patients were randomized to receive the standard of care, which is osimertinib, versus osimertinib plus chemotherapy, platinum pemetrexed. And as you can see in both graphs here on the left and to the right, there is an improvement with addition of chemotherapy to osimertinib. On the graph in A, you can see in the intention to treat analysis, I believe, yeah. Whereas on the right side, it's progression-free survival for patients who had metastasis to their CNS. There might be a little bit more pronounced benefit there. So that is a consideration that we have in the clinic when we're considering patients for these strategies. And this regimen, osimertinib plus chemo, received its FDA approval in February of this year. Next slide, please. And there comes the Mariposa trial. So the Mariposa trial uses a different strategy, which is a novel drug called amivantamab. Amivantamab is a bispecific antibody that targets EGFR and another cell surface receptor called MET, M-E-T. And it's mainly because one of the main resistance mechanisms to EGFR TKIs could be amplification of the MET gene. So in this study, the patients with metastatic EGFR mutated non-small cell lung cancer were randomized into 3 groups to receive amivantamab plus another EGFR targeting TKI called lazertinib. Another arm received lazertinib alone, and arm B received the standard of care osimertinib. And then investigators evaluated the patients in terms of their progression-free survival and overall survival. Again, as you can see, there was a benefit in the amivantamab plus lazertinib arm. And this regimen also received its FDA approval about 3 months ago in August 19. Next slide, please. And now I want to switch gears and talk a little bit about a different mutations or genomic alteration called the ALK mutation. So the ALK mutation we see in about 3 to 5% of non-small cell lung cancer. And the ALINA trial was also a recent development over the past year. What this study did was that in patients who had resectable lung cancer that had the ALK mutation, and they had that cancer, in fact, resected, they were randomized to receive chemotherapy in the control arm, the red boxes, versus an ALK inhibiting tyrosine kinase inhibitor, an ALK inhibiting TKI called alectinib. And these patients were monitored for their disease-free survival. And this study also showed the benefit from alectinib. We call that adjuvant alectinib, meaning after surgery, compared to the chemotherapy, and resulted in FDA approval of adjuvant alectinib for resected ALK-mutated non-small cell lung cancer in April of this year. Next slide, please. So how are we moving the needle with perioperative targeted therapy, meaning that we know that targeted therapies have established efficacy and safety in a stage 4 that is oncogene driven, meaning that we are able to find that actionable mutation. What is their role for this? I talked about the ALINA trial in the last slide, and also about the LAURA trial, like after chemoradiation for patients who have the EGFR mutation. But can we look into other genomic changes, or how about if we give the targeted therapy before actually the surgery for patients who have resectable cancer? And this is the purpose of these ongoing trials that you're seeing here. The ADAURA-2 trial is looking into the benefit of osimertinib in patients with stage 1A2 and 1A3, very early stage, that have the EGFR mutation. When they get it resected, if they get the osimertinib, are they going to live longer cancer-free? So that's the purpose of ADAURA-2. The target trial is extending the use of osimertinib after resection of EGFR-mutated lung cancer to 5 years instead of 3 years. And there are some other trials that you can see in here, such as the Nautica one, the NEO-ADAURA trial, and ALNEO trial that are going to shed some light on these questions, maybe in the next couple of years. Next slide, please. Now let's talk a little bit about the immunotherapy developments. So immunotherapy has been around for some time now. In the non-small cell lung cancer space, the first approvals, in fact, came back in, you can see here in the upper part of the graph in 2015. Nivolumab received the first approval in the US for use in stage 4 non-small cell lung cancer. And then came along atezolizumab, pembrolizumab. These are all immunotherapy options that we have. And there was lots of trials coming out that combined immunotherapy with chemotherapy, with anti-angiogenic medications, and looked into the efficacy and safety of those, which resulted into options that are available in this day and age on the NCCN. But when we look at the role of immunotherapy in local regional disease, meaning non-metastatic stage 1 to 3, it has been only in the past few years, maybe the past 3 or 4 years, that we've been really combining immunotherapy with chemo to see if it can improve outcomes. Next slide, please. So in that line, the first study that came out was the Checkmate 816 study. And this study was a phase 3 study that randomized patients with stage 1B to 3A non-small cell lung cancer. And these were patients whose cancer was considered to be resectable, meaning that we can take it out with surgery, to receive chemotherapy every 3 weeks for 3 cycles versus chemotherapy plus immunotherapy, the nivolumab. Nivo stands for nivolumab. And then the patients underwent surgery, and then they were followed. And the 4-year event-free survival of this study was presented at ASCO this year. And as you can see in here, it showed that patients with in the immunotherapy, chemoimmunotherapy arm, they had event-free survivals compared to the patients who had received chemotherapy alone. And in fact, this resulted in the FDA approval and subsequent NCCN recommendation of this neoadjuvant chemoimmunotherapy regimen, meaning prior to surgery for resectable lung cancer. Next slide, please. And so I talked about this paradigm that we can combine chemoimmunotherapy before surgery, but could there be a role for continuation of the immunotherapy after the cancer is removed? There could be, and that's been the question that multiple clinical trials in the past couple of years tried to answer to, including perioperative chemo plus pembrolizumab, another immunotherapy. And when I say perioperative, I mean before and after surgery, the continuation of immunotherapy after the surgery. Perioperative chemo plus nivolumab, perioperative chemo plus durvalumab, another immune checkpoint inhibitor. You can see the name of the studies here, and in parentheses, I actually have the dates for their FDA approval. So all of these regimens as of now have been FDA approved, with perioperative chemo and immunotherapy receiving its FDA approval now about 2 months ago, and with durvalumab also about 3-4 months ago. Next slide, please. There are certain evidence gaps in this space that we need to find answers to. Well, as you saw, we have multiple options available. So it's a question for us in the clinic, which regimen to use. Is there any differences in terms of efficacy or tolerability? So those are all open questions. We don't have head-to-head trials for different immune checkpoint inhibitors. What are some of the biomarkers of response to the immunotherapies that we can use? It's an active area of research. Does the responses necessarily correlate with expression of PD-L1, which is the cell surface immune marker, so to speak? What is the optimal number of cycles of chemoimmunotherapy before surgery that we have to provide, that we have to give to improve our outcomes in terms of pathologic responses? Of course, giving more treatment might be considered a good thing, but as a matter of fact, it comes with the risk of over-treatment and adding toxicity. So the optimum number of cycles is not known as of now. And then lots of these trials, they used pathological response rates as their surrogate endpoints of patients' outcomes, such as disease-free survival and overall survival. Whether pathological responses really translate into outcomes, improved outcomes and improved survivals, it is a matter of debate as well. Next slide, please. So what's next? So I talked about the recent developments in the targeted therapies space as well as immunotherapies. Now, lots of the clinical trials that are moving in the space are looking at novel targeted therapies after resistance develops to first-line options in the metastatic setting. Also, as I alluded to earlier, the role of targeted therapies, TKIs, in the perioperative non-small cell lung cancer, meaning before and after surgery. And also, we're looking at novel immunotherapies, some of which you can see in the small table on the bottom left, bispecific antibodies, as well as antibody drug conjugates. You can see in this small picture the structure of an antibody drug conjugate. As the name implies, it's an antibody that's attached to a chemo drug, and that antibody specifically targets a certain protein or antigen on the surface of the cancer. And when that happens, that ADC or antibody drug conjugates enters the cells, and then it releases the chemo compound, which results in apoptosis or death of the cancer cell. So they're kind of like targeted therapy, or maybe something between targeted therapy and chemotherapy. There has been an explosion of clinical trials looking at the role of ADCs in the lung cancer, and we have to stay tuned for the data to come out. And believe it or not, I actually asked AI to draw a picture of me being excited about a novel drug in oncology, and this was the end result. Next slide, please. All right, so what else can we do to actually improve outcomes? As you can see, most of my talk so far has been focused on efficacy, but how about safety and how about tolerability? Absolutely, this is something that, in my personal opinion, in the realm of non-small cell lung cancer has been lagging behind, and I think it's really time for us to shift gears a little bit and think about what can we do to mitigate toxicity for these effective drugs that are, improved outcomes and survivals for the patients. So some of the things that we can do is to find the right dose of these medications, and also intervals and routes of administration. One of the studies that I would like to point out to that came out last year is this study on the bottom that I've mentioned, the INSIGN-001 trial. And this study looked at a particular drug called atezolizumab. And atezo is an immune checkpoint inhibitor. It already has FDA approvals for use for different settings in lung cancer. And what the investigators did was that they compared the efficacy of the drug in IV, as IV, and also as sub-Q under the skin injections. And it turns out they're actually pretty equal, or I should say like non-inferior to each other. So this study actually showed that atezolizumab given as sub-Q injection has comparable efficacy to the IV drug. And this resulted in FDA approval of sub-Q atezo, again, about 2 to 3 months ago. And another study that I would like to point out to is this study that looked at the specific drug that I mentioned in the EGFR space, the amivantamab, which is a bispecific antibody against EGFR and MET. And what they did in the investigators is that they compared IV amivantamab again to sub-Q under the skin amivantamab. And the main reasoning behind this study was that amivantamab is a hard drug. It is associated with more than 50% infusion-related reactions. The patients should be pre-treated heavily with antihistamines, steroids before getting amivantamab. So the sub-Q could have been, this was the hypothesis, could it be actually associated with lower infusion-related reactions? And it seems like to be the case. So as you can see in this graph on the right side, the sub-Q amivantamab actually resulted in 13% infusion-related reactions compared to 66%. So this is a phase 3 study that was again announced at ASCO. So they have to stay tuned to see if it receives any approval or not. But these are some of the strategies that we have put into place to improve tolerability in addition to basically improving outcomes for patients. Next slide, please. All right, very good. So it was only 20 minutes, so I tried to just touch on the highlights, but I think we went over some of the most important updates with respect to the management of non-small cell lung cancer, in particular targeted therapies and immunotherapies. And we've come a long way for sure, and we continue to make strides in this field, and we have a long way to go as well. I'll be happy to take on any questions.
Thank you, Dr. Patari. If there's any questions anybody may have, they may type them into the chat by clicking chat on the top of your screen and typing in any questions that you may have. Looks like Dr. Desai had a comment to just say excellent overview, but no questions at the moment. There is one person typing, no questions, great information. Excited for what the future holds for lung cancer. So thank you, Dr. Bidari. Sure. If any come along, we'll make sure to get them over to you and get answers to them. Absolutely. Appreciate your time this evening.
My pleasure. Thank you so much for having me.
I'd like to now introduce Christina Hamilton, who is our Director of Advocacy of Illinois and Iowa.
Thanks, Danielle. Hi, everybody. I'm really excited to be with you all this evening to share a little bit about a couple of lung cancer initiatives happening in the state of Illinois. Next slide, please. So first, I will give some highlights about our annual State of Lung Cancer report. We released our 7th annual report on the 19th of this month. And this provides an overview of how states are doing when it comes to lung cancer. So it takes a comprehensive look at the impact of lung cancer at the state level across the country, as well as opportunities to save lives. And the report found that every state can do more to prevent lung cancer, including Illinois. Next slide, please. So here is an overview of the indicators that we include in the report, including surgery, new cases, and screening rates. So not all patients require surgery, but for those where surgery is recommended, we assess how many of those patients actually are receiving surgery. And then, of course, we share updates on the incidence of lung cancer, and we provide it per 100,000 people, and then the screening rate. One note, our screening rate in the 2024 report can't be compared to screening rates in previous reports because we have used a different data source for 2024. Next slide, please. So to start, the disparities in lung cancer do persist. One highlighted disparity is that Asian and Pacific Islander individuals are least likely to be diagnosed early, and I'll talk about why that's important in a couple of slides. We also see that Black individuals still develop lung cancer at the highest rates statewide. You can see that for surgery, screening, and new cases, we are about average across the board. For our new cases, the rate is 58.7 per 100,000 people. Nationally, it's 53.6. For surgery, it's 21% of patients receive surgery. That's pretty similar to the national average of 20.7. And then for screening, the rate is 17.4, and the national average is 16%. So certainly a lot of area for improvement for all of these indicators, but we do fall at about average for all of these areas. Next slide, please. So we also assess the survival rate, lack of treatment, early diagnosis, and comprehensive biomarker testing. And the biomarker testing indicator is new for this year's report. So survival rate, good news here, nationwide, the survival rate has improved 26% over the last 5 years. So that definitely gives us a lot of hope that, we're going in the right direction, and definitely with a lot of the updates that Dr. Paidari shared about all the new research and medications and biomarker testing, the survival rate is definitely reflecting a lot of those advancements. And then also lack of treatment. There's still quite a bit of work to do to ensure that those that are diagnosed do receive the treatment that is recommended. Early stage diagnosis is key when the disease has not spread and is more likely to be treated or be cured. And then finally, biomarker testing. Dr. Paidari did a great job of, giving an update on all the advancements in biomarker testing. And we have now added this indicator to our report to highlight which states are covering biomarker testing. Next slide, please. So you can see here that once again, we're about average for most of the categories here. The 5-year survival rate in Illinois is 29.1%, which is similar to the national rate of 28.4. We see that for lack of treatment, 18% of patients did not receive treatment for their lung cancer, which is less than the national average of 20.9. For early diagnosis, 28.2% were diagnosed at early stage, compared to the national average of 27.4. And then for biomarker testing, I think Illinois was actually the first state to require Illinois regulated health insurance plans to cover biomarker testing. Again, you heard earlier just the importance of testing for biomarkers, being able to identify targeted treatment for patients to improve lung cancer outcomes is critical. So we're happy that in Illinois, that testing is covered by insurance and has been for a few years now. Our smoking rate is about average. It's similar to the national rate. It's 12.4% of adults currently. And then for radon, we are one of the states that doesn't perform as well when it comes to radon, which is a colorless, odorless gas that's naturally occurring in the ground and is captured in buildings. And it is the second leading cause of lung cancer. And the only way to know if radon is present in your building is to test for it. So we do have work to do there for radon mitigation and awareness. Next slide, please. So that's an overview of our state of lung cancer report. We encourage you to share that report out with your patients, your communities. We want to spread as much awareness as we can about the importance of improving in various indicators to improve lung cancer outcomes. So next I will talk about a local initiative called the Illinois Lung Cancer Screening Initiative. This program is now in its 3rd year. It's funded by the Illinois Department of Public Health, and it's focused on reaching the highest risk people for lung cancer in our state. So I mentioned that Black people develop lung cancer at higher rates. Additionally, white men have high rates of lung cancer and high mortality from lung cancer in our state. So they are the target population for this initiative. And the primary goal is to increase screening, increase awareness, and be able to mitigate different barriers that individuals faced when it comes to accessing lung cancer screening. Next slide, please. So here is an overview of the referrals for screening, the number of low-dose CT scans that occurred, and then the number of referrals for the Illinois Tobacco Quit line. So you can see there's some, kind of ups and downs in the trends with this initiative, but overall, it was 14,000 people. Yeah, over 14,000 people were referred for screening, and then 10,000 of them actually were screened. So these are very positive numbers. The partners that are involved with the initiative, which I'll talk about in a couple slides, have increased their referrals of low-dose CT scans. They've integrated more lung cancer education into their practices. And we were actually working under less funding in FY24. So it is really promising to see these numbers and referrals in the second year of the project. The first year was FY23. And also now the Quit Line is counseling all callers that fit the screening guidelines on lung cancer screening. And there's that direct link to the lung cancer screening initiative for those that contact the Quit Line. Next slide, please. So here are some additional results from FY24. You can see here that the conversion rate of those who were referred for a screening and actually obtained the screening is quite high. We also see a high referral rate with the Illinois Tobacco Quit Line. More than 10% of those referred were identified as Black, and then 80% of them went on to obtain a low-dose CT. And then little less than half of those who were referred were still smoking cigarettes. So definitely tobacco cessation is integrated throughout to ensure that we're helping people quit when they are coming and involved in the initiative. Next slide, please. So here are the partners statewide for this initiative in FY24. You can see that we have a spread around northeastern Illinois, central and southern Illinois. The disparity is definitely concentrated in central and southern Illinois. Some of the areas of the state have a mortality rate from lung cancer that's double the average in the Chicagoland area. The smoking rates are higher, but the populations are a lot smaller. But you can get a good idea of the breadth of the partnerships across the state and the funded partners that participate in the quality improvement and really help to spread awareness about the initiative and again increase those screening numbers. Next slide, please. So here is information about the helpline and the resources that our lung health navigators can provide to individuals through the lung cancer screening initiative. You can see the phone number here. It is a national number, but for anyone in Illinois, they will be geolocated to a lung health professional in Illinois to assist them. We can provide information on a nearby screening center, help with scheduling, connect people to transportation and other financial resources. So there's a variety of support that our lung health navigators can provide to individuals who call. We also have a website with more information and an email address, really try to make it as accessible for folks as possible and have opportunities to really support people in their lung cancer journey. So wanted to make sure you're all aware of this resource. Next slide, please. So this story is, what grounds us in this work and why we advocate for lung cancer screening funding at the state level. We want to see this program, grow throughout Illinois and be replicated across the country because we're really seeing that with dedicated resources to lung cancer screening that we can have successes. So here's a highlight of one success story, and I'll just go ahead and read it for you. I know it's a lot of text. So a 63-year-old female called the Lung Association in February and was connected to one of our lung health navigators. During her initial call, she mentioned that she took the Lung Association Saved by the Scan quiz, which informed her that she was eligible for a low-dose CT. She was reaching out for guidance because she was uninsured and was not sure what her next steps were to receive a low-dose CT. In the weeks that followed, the lung health navigator worked with the patient to obtain a referral for a low-dose CT from her primary care physician. And as her primary care physician did not tell her where to get her scan completed, the navigator helped the patient find an imaging center within 8 minutes of her home. The patient was able to schedule a screening for February 22nd, so just a couple weeks after she initially called at Springfield Memorial Hospital. The patient shared that her results indicated that nodules were found, which had remained the same size from previous scans, and that she will continue to be monitored annually. To improve her breathing, the patient was also prescribed medication. The navigator sent her a list of financial resources to help cover the cost of medications. The Lung Association, through funding from the Lung Cancer Screening Initiative, was able to pay the cost of the patient's lung cancer screening, which came to $535. So again, these are the kinds of stories that drive us and keep us motivated, and just as an example of how we are reaching people with this targeted initiative and want to see it grow, because we're really seeing that when you dedicate those resources that you really can reach more people in need and connect them to life-saving care. So next slide, please. So speaking of raising awareness, we would love for you to connect with us through our Lung Action Network. By becoming an advocate, you support making sure that policymakers who are in charge of our state budget, who are in charge of healthcare access and insurance coverage, hear from community members, medical professionals, nurses, all types of healthcare stakeholders about the need to ensure that we continue to raise awareness about lung cancer and so many other lung health issues, and that we continue to support things like the Lung Cancer Screening Initiative and improving access to care. So I encourage you to scan this QR code or go to our website to join our Lung Action Network. And we really try to send timely, actionable updates to the Lung Action Network, and they are specific to Illinois. And again, just the more voices we have involved, the better, to continue to support people with lung cancer and at risk for lung cancer and their loved ones. Next slide, please. So with that, feel free to reach out now or later with any questions. I've also included my colleague, Michaela Pittman's information. She is our fearless leader for the Lung Cancer Screening Initiative and can connect you to our other amazing colleagues who help guide that work in Illinois. Thank you.
Thank you, Christina, for that overview on the programs in our report. I believe during your presentation, we already had a question about your slides and the State of Lung Cancer report. So we did include the link to where you can find that State of Lung Cancer report on the chat if anybody is interested. It looks like we do have a question. What is the eligibility requirements for biomarker screening and where can an individual go?
So the lung cancer screening initiative is the low dose CT screening. So a scan for individuals who have a heavy smoking history. So they smoked a pack of cigarettes a day for 20 years, or they smoked at that amount and they quit within 15 years, and they're between the ages of 50 and 80. So those are the lung cancer screening guidelines for insurance to cover this screening. We do encourage you to still contact our helpline if people don't fit those screening guidelines, and definitely advocate for yourselves with your healthcare provider if you have persistent symptoms that are unexplained. So it's specifically low dose CT screening that is covered by the grant for uninsured and underinsured people. Biomarker testing is a whole nother realm, as Dr. Paidari covered in part of his presentation. Insurance plans do cover biomarker testing, and that is after a lung cancer diagnosis is made, from my understanding. So it's another component of screening, but not what the initiative is directly focused on. Biomarker testing comes later.
Thank you, Christina. And what we will do too, we'll follow up with everybody that is registered for this evening's presentation with those certain links that she had shared as well in regards to our lung screening initiative program and our health navigator program. I'd like to now, as we highlighted the importance of lung cancer screening, I'd like to now play a video of U Chicago Medicine's lung screening program. Thank you.
Is lung cancer screening right for you? Lung cancer does not cause symptoms in its early stages. By the time a patient experiences symptoms, the cancer may be advanced and difficult to cure. The good news is, scientific evidence shows that lung cancer screening can help. With screening, lung cancer can be diagnosed at an early stage when it's more curable. Lung cancer screening involves a low-dose computed tomography, or LDCT scan, of a patient's chest to make detailed pictures of the lungs. Radiologists examine the images for abnormalities that could indicate cancer. The exam is painless, non-invasive, and only takes a few minutes. LDCT screening is recommended for patients who have an increased risk of developing lung cancer, but who are still in reasonably good health. You must meet certain criteria to be considered for lung cancer screening. There are some minor risks associated with LDCT screening. For example, not all nodules are lung cancer, and there may be a need for additional tests and procedures. This can cause anxiety for some patients. Discuss the risks and benefits of LDCT with your doctor. If an abnormality is found on your lung, your doctor may recommend additional tests or schedule a follow-up scan. If your screening shows you may have cancer, our multidisciplinary lung cancer team works together to determine which treatments will be most effective for you. Lung cancer screening can save your life. U Chicago Medicine offers lung cancer screening in several locations. Want more information about lung cancer screening? U Chicago Medicine is here to help. Is lung cancer screening right for you? Is lung cancer?
Thank you. And now I would like to introduce you to Dr. Desai, who will be sharing a presentation on new advances in treatment of lung nodule management, screening, staging, and robotic bronchoscopy. Thank you.
Thank you, Danielle. That was a very timely and very appropriate, segue for the presentation about lung cancer screening. Great talk by both our speakers. Christina, I think the State of Lung Cancer report is really exciting and really promising. I remember when I was in training, and obviously. I did not have any gray hair back then. Our overall survival for lung cancer was 16%, 16.9%, and to Dr. Pedrari, are the only medication that we had in terms of targeted therapy was erlotinib. It's exciting to see the advancements that have been made in biomarkers, the targeted therapy, and also initiatives like lung cancer screening initiative. Um, we can go to the next slide. Uh, these are some of my disclosures, and I also participate in some active research trials. I'm going to speak about some robotic bronchoscopy, and I do speak for them. Also, I'm involved nationally in advocacy, both for education and also for our pulmonary societies. Next slide. So, I took the opportunity to, break down my presentation into three areas, right? I know that Christina covered the screening guidelines. I'm going to speak a little bit more about the guidelines so that, obviously we cannot talk enough about guidelines about lung cancer screening. One of the aspects that we're trying to address after, once we do the low dose CT for lung cancer screening is to find out lung cancer early. So, usually the findings that help us diagnose lung cancer early is called lung nodule. So I'm going to go over how to tackle lung nodule, some of the things that if you are a patient or a caregiver that you should ask your providers during that visit, and also emphasize the importance of staging, which is also a very important part of lung cancer diagnosis. Next slide, please. So, what we know is lung cancer detected in its earliest stages has the best outcome. So when you look at, to when you look at this chart and to the left-hand side, the blue line is the cancer diagnosed at its earliest, what we call as stage 1A, 1 lung cancer. That is the earliest someone can find lung cancer, and the survival, that means how long someone can survive and live, is about 92%. So, when we say that, that means, that is comparable to survival for breast cancer and colon cancer. But, the reality is that we don't diagnose all lung cancers early, and somewhere in the middle where the stage is, advanced or not localized to one area. When lung cancer is diagnosed at the later stages, that means in stage 4 or stage 3, the survival, 5-year survival is extremely low. So what we want to do is we want to find those lung cancers early. Next slide, please. And how do we do that is by low dose CT, as Christina pointed out, and also that video from University of Chicago, low dose CT for lung cancer screening, which is a very simple test, a very quick test. The way this guidelines came up, the U.S. Preventive Services Task Force in 2013, they released a guideline, emphasizing screening, and these are some of the requirements. Some more data came in, new data. That is the Nelson trial, which was published recently, which led to upgrade or sort of expand the lung cancer screening guidelines. And where we stand right now is age 50 to 80. So someone who is 50 to 80 years of age, who's a current or former smoker, and who has smoked about 20 pack year smoking history, they should be getting a lung cancer screening. Oftentimes, I get asked, a question that, Dr. Desai, how long should I continue with screening? And someone should get screening annually. Either they have quit smoking for 15 years. So when you reach that 15-year mark, you should stop screening. Or if, by guidelines, when you turn 80, the recommendations are you can stop screening at that point as well. So, and it should be done annually up until then. And that's really the guideline right now. Next slide. So, low-dose CT, the goal of low-dose CT is to detect lung cancer early. And oftentimes, the abnormality that we find is called a lung nodule. Now, understanding that not every nodule that is detected in the lung is going to be cancer. So that is an important part to understand. So oftentimes I get asked, what is a lung nodule? So a lung nodule is a round or oval lesion in the lung that is seen on chest x-ray, or in this case, a CT scan. So the picture that you're seeing on the left-hand side is a picture of a CT scan, or one of the images of a CT scan, which is a cross section. So patient was laying on the CT scanner, the table. The scanner came in and took slices of their lung, and this is one of the slices. So you can see here on the left-hand side, you can see the black area, that's the lung, left lung. And on the right-hand side, you can see the black area, that is the right lung. On the right-hand side, there is a small area right here. I'm not sure if you can see my arrow, but there is a small spot on the right-hand side in the middle of the lung, and that's the lung nodule. Now that's a very small lung nodule. There you go. The arrow comes up, and that is the lung nodule. Now that actually turned out to be a lung cancer. And when that was diagnosed, it was in its earliest stages. So stage 1A. And that actually was resected by surgery, and this patient is cured of lung cancer. We followed obviously the patient for 5 years, but the cancer didn't come back. So a very great outcome, and you want to detect lung cancer in this earliest stages. Next slide. So, but again, not all lung nodules are cancerous. So these are some of the list of reasons why lung nodules can be seen. The cancerous causes, so primary lung cancer, sometimes cancers like carcinoid tumors, lymphoma. Sometimes cancer can be a reflection of spread from other parts of the body. So that is also something that we have to keep in mind. Non-cancerous causes. There are very long non-cancerous causes. Now, one of the common things that we encounter in the Midwest is fungal infection affecting the lungs and causing that nodule. There is a couple of infections that we commonly see, what we call as histoplasmosis, blastomycosis, and also in areas where someone has traveled to Arizona. I can tell you, I think, you see a lot of people that, don't like winter in Chicago. So they go to Arizona and spend time there. So they're exposed to another fungal infection called coccidomycosis. So something to keep in mind. Next slide. So, these are some of the things that, I put together, as questions, right? So oftentimes I get asked when I'm in the clinic, when I'm seeing patients who get referred to me for lung nodules, and these are some of the questions that they have in their mind. And if you're going to see a doctor who specializes in lung nodules, these are some of the questions that, you should be keeping in mind as well. So what is the size of the nodule? So you want to know what the size of the nodule is, because we know from evidence that larger the nodule, bigger the nodule, the higher the chance of cancer. So, and also on the other hand, smaller the size, the lower chance of it being cancerous. What type of nodule do I have, or what type of nodule that your loved one has? Is it, a solid, a subsolid, or part solid nodule? What is the risk of this being cancer? So, and I'll go in the next few slides, what goes on in my mind in our clinic when we are evaluating for lung cancer. What are the tools that we use to come up with a risk for our patients? And then, there are some new techniques or new tests that are available that can help us even further risk stratify nodules which have been detected. And you may want to ask your doctor, am I a good candidate for that blood test? Do I need a biopsy? Can we just watch it by scan, or do I need to go up with a biopsy early? Now, all those things depends on the risk that we identified. Now, do I have lymph nodes that are affected? Right. So those, as I said, lung cancer staging is very important. You want to diagnose lung cancer early, but at the same time, you want to diagnose the most appropriate stage. Lymph nodes have to be one of the important parts that you have to ask your doctor. Now, also, I can't emphasize enough, you need to, ask your doctor some of these questions. Does my doctor specialize in lung nodules? You don't want someone who's seeing a lung nodule once in one nodule in a year, or two or four or five nodules in a year. You want doctors who are specialized in lung nodules to be the one. The reason why is because the techniques that they will be learning, or even or not doing procedures, are going to be very important to you as well, because sometimes less is more, but at the same time, understanding the importance of diagnosing early lung cancer is also important. And also, does my doctor or surgeon perform minimally invasive procedures? What we know from evidence is that when you have less invasive procedures, there's less chance of complications. Next slide, please. So as I said, size matters. Overall, 5% of only 5% of nodules are cancers. So you have to be very cautious, right? So not all cancers, all lung nodules are cancerous, and overwhelming majority are not cancerous. But we want to detect lung cancer at its earliest stages. So the onus becomes on your doctors and also your team of physicians and providers to come up with the right strategy. We also know when the size gets bigger, the chances get higher that it is cancerous. So this is sort of the picture on the right hand side shows you really when we talk about millimeters, because we don't learn millimeters in school all the time, right? But as in medicine, we use all the time centimeters and millimeters. They're not usually used metrics. So when I talk to my patients, I tell them millimeters. I tell, they oftentimes you get asked that, what does that mean? So a tip of the pencil or the eraser is 5 millimeters. Oat cereal is 10 millimeters. A penny is 2 centimeters. That is about 20 millimeters. And 4 centimeters is a golf ball. So, something to keep in mind, when you look at it, and when someone says that someone has a 2 centimeter nodule, that means it's a size of a penny. Next slide, please. So, when we talk about risk for lung cancer, we are talking about, someone's age. So age is important because, we know from evidence that, as the risk for a 40-year-old, maybe, someone who has who's 60-year-old, or will be very different compared to a 40-year-old. So 60, the risk will be higher compared to 40. And history of cancer. If someone has a history of cancer, then the risk of the nodule being cancerous is higher. Size, as I mentioned, shape, how does the nodule look? Does it have any features of speculations? Those are important, aspects to remember. Also asking your physician, do you see that? Next slide. And when we look at lung nodule, when we are providing lung nodule care, and one of the goals that I, in my program, which I have developed, is that we want to make sure our patients, regardless of how they we find the lung nodule, it could be because of the low dose CT, or incidentally, when we find lung nodule, is to move the patient quickly and diagnose them early. If they need an intervention to find out what it is, a lung nodule diagnosis, if it is lung cancer, stage it early and then get to the treatment as quickly as possible. And as was emphasized in that video, also in our program, we have what we call as multidisciplinary program, where it's a team effort, where you have thoracic surgeon, interventional pulmonologists like myself, nurse navigators, we have our radiologists, pathologists, oncologists, and radiation oncologists. We all sit down together every Tuesday, review our patients' scans. We talk about treatment pathways and come up with the best treatment approach for our patients. So what the patients should go through is minimal interaction within the healthcare, healthcare service, but get to that treatment plan as soon as possible. Next slide, please. So, this is what goes on in our mind when we are looking at our patient. They come into the clinic. So the first thing we look at is, okay, we found the nodule. Is it from incidental lung nodule or from lung cancer screening? The reason it makes a difference is because the guidelines and the prediction models, that means, things that we use, calculators or models that we use to predict a risk for lung cancer or cancer, is different. But these are some of the tools in our armamentarium that helps us assess the risk for a lung nodule. Next slide. And these are some of the models that are available that are very well established and evidence based, and they have a lot of validity, and they're very helpful tools in predicting lung nodules. Next slide, please. And then, what we know is that most of the patients, right? Most of the patients don't have high risk. Oftentimes, if someone has a very high risk nodule, that means, if someone has a nodule, that it's, say, for example, 70% chance that is going to be cancerous. Now, oftentimes those patients directly go for biopsy, or, if someone wants to proceed directly with surgery, we will proceed with surgery as well. If someone has a lung nodule that has very low risk features, that means the chances of cancer is extremely low. Oftentimes, we don't do anything except getting a CT scan in a few months to make sure this nodule is not growing, and we monitor it over a period of time. But the reality is, bulk of the nodules are between the low and the high risk. So they're in the low to moderate risk category, and oftentimes we have to come up with a plan where we either consider biopsy or even do another additional testing like PET scan. Next slide. In this setting, one of the tests that has evolved and had come about new, and as I was actually fortunate to be a researcher and in part of a research trial that led to approval of this blood test, was it's really helpful in our lung nodule care. This test is called notified testing. It's a blood-based test. It can help us identify if someone has more risk factors for infection or more risk factors for cancer. So essentially, someone in the sort of the low to moderate risk category can shift them to the high risk category, or if they're low in the moderate risk, to the very low category. So a very useful test when done and when it can give us good results. Next slide. So, when we have gone through the risk factors and they need a biopsy, that we have now minimally invasive tools such as endobronchial ultrasound and robotic bronchoscopy. Next slide. So we didn't have that long time ago. It has evolved. We had bronchoscopy, electromagnetic navigation, needle biopsy that goes directly from the chest, but it penetrates and pierces the lungs and then makes its way into the lung nodule. It does have a good a chance of getting an answer, but it also has a high risk of complications. And then sometimes we directly go to surgery, where that can be an option as well to diagnose. That means to find out and also treat it at the same time. But more recently, we have had tools such as ION. Next slide, or we can advance this. We have ION robotic bronchoscopy that is less invasive, and it's helped us diagnose these lung nodules very accurately, but importantly in a safe manner. So very important addition to our tool. Next slide. And really, the advantage of ion or robotic bronchoscopy has been that it has more reach. That means it can go really deep down into the really small, tiny airways into the lung, with a lot of precision and stability. And so, really, it has been a game changer in terms of lung nodule diagnosis. Next slide, please. So, before I dive into robotic bronchoscopy, I'm going to go over, try to, sort of go over, walk you through some of the basics. What is a bronchoscopy? So, a bronchoscopy is a technique that we use to look at the passages, the airway passages, with a very small, tiny camera that is located at the end of a flexible tube. Oftentimes, when I'm going over these procedures, I tell my patients that, it's very similar to colonoscopy, right? So colonoscopy has also a camera, and it's a long tube that goes into the colon to look at the colon. Here, bronchoscopy is really looking at the bronchial tubes or the bronchial airways. The video is connected to a screen, that is on the, and oftentimes now a joke, obviously everything is getting high definition. So we also have high definition camera and high definition screens that help us see those details in the lung. And then, we use tools. Once we get to the lung nodule, we use tools like biopsy forceps or needles to get sample from the nodules or the lymph nodes, what we are looking at. Next slide. So really, what is a robotic bronchoscopy? It has, these 5 things that, we look at, right? So it is an advanced development of bronchoscopy. So essentially an extension of bronchoscopy, but now it is advanced. It's robotically driven, and the entire catheter has shape sensors that help us get to those difficult to reach areas. This technology allows physicians who specialize in interventions and bronchoscopy to get those, deep down airways. And once you reach those airways, we can pass those instruments and get biopsies from there. And really, this allows your physicians to diagnose lung nodules, even with the smallest of lung nodules, and diagnose them early. Next slide, please. So, when we talk about, robotic bronchoscopy, it's like GPS of the lungs. So, remember back in the day, we used road maps, right? Paper road maps. I'm not sure if anyone, is still using road maps, but it really changed, how we use it after GPS was introduced, right? So I don't remember any time now using paper road maps. My son, 15-year-old son, I don't think he's ever, will understand what a paper roadmap is ever. And so that's what GPS did to us, right? GPS made it more efficient and help us get from point A to point B. Now, I joke about it is that bronchoscopy without navigation or robotic assistance is very similar to paper roadmaps. It can get us there, but really it's, once robotic bronchoscopy was introduced, it's sort of, robotic routine bronchoscopy is not, being utilized as much. So with the robotic bronchoscopy, it also has within itself, it has the GPS or the navigation system. So when we are doing a procedure, the robot is directing us, okay, make a right, make a left, and then it gets us to our destination. In this case, it's the lung nodule that we're trying to get to. So once we reach there, the robot can actually, tell us exactly how far away from the nodule we are, and then we can use our tools. So very, very important, addition, the GPS of the lungs. That's what robotic bronchoscopy is. Next slide, please. So, the evidence is building. There's more and more evidence because it is a new technology. It was introduced about 4 years ago, and now we have enough data, and many of us who have done, several hundred cases of these are pulling up the data. What we have seen is the chance of getting an answer is very good. 90% of the times we get an answer. Some studies have shown even 94% of the times, and the biggest part which we have seen is that the chances of getting a pneumothorax or any complication is extremely low as well. So less than 1%. Next slide. So, oftentimes I get asked that, and by my colleagues in our conferences or even our patients, that what about the needle that goes from outside? Can we just do that? And so, yes, it is a good option and especially in centers that don't have robotic bronchoscopy. But this study from Mayo actually compared the two technologies, right? Robotic bronchoscopy and the needle from outside to get a biopsy. What they found was the chances of getting an answer are very similar, or I would say same compared between the two. So both are very good at finding out what it is. The difference is the complication. That means the problem, right? The complication rates are way higher when someone underwent a CT guided needle biopsy. When you look at the pneumothorax, the lung collapse, 17% compared to 4.4% in this study when you look at it. Now that is a high number, so the higher chance of complications. But one of the other things is that, remember I talked about staging. We want to look at the lymph nodes. The bronchoscopy during that same procedure is able to get us lymph nodes staging as well. Whereas in patients who had undergone CT guided needle biopsy, they had to go through they had to go through a bronchoscopy, a second procedure. So you get one procedure and you have to wait for the results, and you go undergo another procedure to just look at this lymph node. So bronchoscopy can help us diagnose and stage at the same time. Next slide, please. And we have other tools like cryobiopsy to get a better sample during the procedure. Next slide. This is my experience. Now I have done more than 500 cases, 550 cases. When I put together this slide, since then, it is the number has gone up, and our rates are very similar to what has been reported, and also the complication rates are very low. Next slide, please. This is an example. I'm just going to go very quickly. This is of a patient who who underwent a low-dose CT scan and was found to have a lung nodule. But the lung nodule was located in a very difficult situation. We can advance the slide so that we can see the arrows. So this is the red arrow points towards the nodule that was detected on the CT scan, and in a slightly different view of the lung nodule. We can advance the slide. To this red arrow pointing out, that's the same nodule, but looking at it in a very different, in different cuts. Next slide. So what we did was we started planning, and then what I did was I proceeded with planning for the robotic bronchoscopy. So what the patient underwent was a CT scan of the chest. We loaded into our software, created a roadmap, and during the procedure, when the patient is anesthetized, that means under anesthesia, we proceed with navigation. We start with first evaluating the airways, and then the pathway is created. And if you can look at it on the left-hand side, there's a virtual path in the left lower corner is your GPS or a virtual path telling you that, okay, this is the path that you need to follow and we follow that blue line or that blue snake-like line that comes up, and we follow and reach to the nodule, as you can see. And the next video is a video of how we navigate it. And you can see on the lower right-hand corner, that's a picture of the X-ray that we used during the procedure. And that actually has reached the nodule. And there's additional confirmation. You can see that sort of the blue or blue ball that you can see, that's the nodule, that's the target. The system is so sophisticated that once I reach with my bronchoscope, it tells me how far away I am from the nodule. So I can see that in a metric, we can see, I'm not sure if that is displayed very clearly. I'm about 10 millimeters away from my nodule, and my target is it's right in the middle. So what that tells me that what I need to do is put in my needle about 10 millimeters away, and I will be in the nodule. So very accurate in terms of, the technology. Next slide, please. And this patient actually turned out that this patient did have, unfortunately, lung cancer. But luckily for this patient, did not find any lymph nodes. This patient underwent surgical resection, and this surgical resection happened about 2.5 years ago, and still this patient is cancer-free. Next slide, please. So, I'm not going to go into all the details, but it is very important that, we look at lymph nodes. There are a lot of lymph nodes. Lymph nodes are normally present in all of us. They're organs that drain the blood supply or sort of act as filters, very useful for our infection and also draining any impurities. Everyone has lymph nodes, and these are all those areas where the lymph nodes are present. Next slide. It's also important because a lot of the cancers can spread to these lymph nodes. So it's a very, very important step for us to take a look if there's any cancer spread to the lymph nodes. Next slide. And how do we do that? We do that with a tool called endobronchial ultrasound. As I mentioned, we can diagnose with the robotic bronchoscopy. And then obviously, once we're done with the robot, we take the robot out and put in a bronchoscope, which has an endobronchial ultrasound at the tip. And we take samples from there. And in the top right-hand video corner, there's a video of a small needle going in and out very precisely into that small area. That's the lymph node, and we are sampling that. So this patient also turned out to be, having a positive lymph node. Next slide, please. And EBUS is really changed the way we sample lymph nodes, and now it has become the standard of care for sampling lymph nodes. Next slide. So, in conclusion, I'm just wanted to summarize, what I have talked about. Low dose CT for lung cancer screening is a very, very important life-saving intervention, especially for our high-risk patients, 50 to 80, 20-pack year smoking history. It helps detect lung cancer early, and that helps us improve the chances of cure and survival. Lung nodule management is complex, and it requires a team to accomplish these things. Newer technologies like blood-based test for risk stratification like Notify, minimally invasive tools like EBUS and robotic bronchoscopy are making it really, really important, are making it easier for physicians, and also has been game changing for our patients to diagnose lung cancers early, and really can be accomplished in one single procedure, and so that patients don't have to go through multiple procedures. And with that, I'm going to conclude my talk, and happy to take any questions.
Thank you, Dr. Desai. Any questions, please feel free to plug into the chat. Okay. It looks like we may not have any questions, but thank you to you, Dr. Desai, for your time this evening to spend with us, and for Christina and Dr. Padari to really share. There's questions in the Q&A section in Teams. Laura just wrote, not too sure if. Sorry,
Yes, I see a few of those here, Danielle. I can read them off if you'd like.
Go ahead, please.
Yes. One question here, do you think AI will eventually be involved in robotic bronchoscopy?
I think I would say, AI is a very important tool, and certainly I would say that before it gets into robotic bronchoscopy, I see that AI will be playing a big part in lung nodule detection, and obviously identifying patients who can qualify for lung cancer screening. And oftentimes they get CT scans, say, for example, if someone has a chest pain, right, and they get, chest pain, but by the way, there was a 5 millimeter nodule that was there that someone needs to follow. AI might help us detect it and tell the physicians that, okay, hey, listen, this patient had a 5 millimeter lung nodule. Can you follow that up? Or even AI might detect those cancers earlier as well. So I'm excited about AI being in lung nodule space, but I would say their best role would be, or I would see that evolving role in the lung nodule detection and lung cancer detection early.
Great. I have another question here. Are all insurance companies paying for, it says Notify, and they're wondering about the cost of robotic bronchoscopy.
Yeah, very good question. I think I would say that most of the companies, or I would say insurance companies, are approving Notify. I would say that there is CMS is definitely, Medicare is covering Notify. There are some insurance companies that may not cover. What I know is that from the company that makes the blood test, they will actually pay for those, or I would say free of cost to the patients as well. So oftentimes, I've had very few patients who actually did not qualify, and the company actually has paid for those as well. So I think for the cost for the patients, it is usually not there, for the patients. And the second question was, how expensive is robotic bronchoscopy, or I think I would say twofold. One is, obviously it comes from the patient side of it, and comes from, the healthcare or hospital side, right? From a healthcare and hospital side, it actually is one of the technologies that I feel is one of the most value-based technologies. That means with minimally invasive tools, without causing any complications, you're diagnosing early, and you're preventing those patients from developing complications and treating them at the earliest stages. So, as a healthcare initiative, when you look at the cost that goes in when someone is getting diagnosed as stage 3 and stage 4 later on, uh, it's huge. Any of these medications that we talked about, the chemotherapy or immunotherapy or targeted therapy, the expenditure that goes into that is extremely high. So we would want to diagnose lung cancer early. So that said, from the hospital and healthcare perspective, it is very favorable in terms of when you compare with those technologies. When you compare with the patient, now, as with thanks to advocacy from ALA, from our pulmonary societies, most of the insurance companies are covering for robotic bronchoscopy. So for the patient, if the provider and the physicians go through appropriate prior authorization, the cost to the patients are going to be minimal, or is not going to be very high.
Thank you for speaking to the cost. That's obviously a very important factor. I have just two more questions that I'm seeing in the Q&A section. If there's any other ones, please drop them either there in the chat, folks. One here is saying, if someone had a successful needle biopsy, what would be an indication to that they would then need a bronchoscopy as well?
Very good question. So if someone has a successful needle biopsy, often and it turns out that nodule or that biopsy is cancerous, right? So if the nodule is cancerous, then there will be some series of tests like a PET scan that is done that will help us stage. That means make sure there is no spread of cancer elsewhere. If those tests, the PET scan does not show any cancer elsewhere, and if someone is a candidate for surgery, then there will be no need for bronchoscopy, right? So there's no need for bronchoscopy, and someone can go in and get the surgery and get that out. Now, but the PET scan, unfortunately, sometimes may show, activity in the lymph nodes or spread anywhere else. In that situation, bronchoscopy is needed to biopsy and stage the mediastinum, or biopsy those lymph nodes. So it all depends on, some additional testing called PET scan, whether there is any evidence of spread to anywhere in the chest or what have you.
Thanks. It's very helpful. And then our last question that I will read just as we wrap up states, for those not eligible for lung cancer screening, what do you recommend to your patients if they have other high-risk factors, such as family history or radon exposure?
Yeah, great question, a great question, and that is the gap, right? That's the gap in our understanding. We know that not all cancers are because of smoking, right? We also know that, non-smokers get lung cancer as well. So what we are learning, and we are trying to identify those high risk population, and there is some guidelines from NCCN, with the calculation based on that if someone has high risk features, that they may be eligible for, they must get low dose CT or lung cancer screening. Unfortunately, those things are not approved by many of the insurance. You can get, if you're high risk, from because of radon and whatnot, then you can talk to your provider. They may direct you to facilities where you can get out of pocket, or maybe, at a very low cost, get screening. But I strongly encourage making sure that you're going through a shared decision making, or process with your provider, to make sure that you understand the risk and benefits when you're getting those scans as well. But, to answer your question, and, in a short answer for that, there is no guideline right now that recommends screening apart from the group that we talked about.
Thank you very much. I believe that's all the questions we have.
Thank you, Dr. Desai, and thank you, Timmy, for reading those off. I want to
My
share
pleasure.
a thank you to everybody for their time this evening to tune in. We hope you leave today with some insight on advancements in lung cancer, knowledge on our state of lung cancer report, and some initiatives that we have locally as well. And just want to share with you, to continue to be involved. Feel free to reach out to anybody on the American Lung Association team for more information. There is our Fight for Air climbs that are coming up, which is one in Oak Brook and one in Chicago. So stay tuned, take a look. Feel free to get some information online. Register yourself or a team or your institution to come and join us. Thank you. Have a good evening, and hope everybody has a wonderful Thanksgiving holiday.